Good evening, everybody. I'm Dr. Deepak Gupta. I'm the consultant in the critical care at Kailash Deepak Hospital. I think you all should have started studying, filled the forms for EDIC 2. This is the first type of a bit of introduction I'll be giving regarding EDIC 2, and the first case we'll be seeing, that is the respiratory case, very important, carries lots of marks. So whatever you know, you can say, we'll discuss it further. Okay, it will be an interactive session. So first few minutes, I just wanted to tell you, most of you are appearing for the first time. Any repeaters in this? Okay, just a short few slides regarding what pattern and how the EDIC 2 exam goes. Actually, it's the examination is divided into two parts, that the CCS and the CBS. CCS are the clinical case scenarios and CBS is the computer-based scenarios. Okay, in the clinical case scenarios, there are two stations, two of the CCS stations, one long case each, and two short cases. Previously, they used to have three long cases. Now, what they have done is two long cases, and the last long case they have divided into two short cases. Usually, it is kept that the first long case is the medical case, second long case is the surgical or trauma type of case, and the two short cases can come from any field, maybe a poisoning type, drowning type, burn, any of the case, or a typical sepsis type of case. So this is the division what it is being done. Now, what is the time? So first 10 minutes are allowed to read and absorb the opening vignette in each of the long CCS cases, and 25 minutes your viva will go on. Okay, so total 30 minutes for one case, 30 minutes each case, 5 minutes are there allowed, in which the changeover will take place. The examiner will change. Previously, what happened in offline cases, the students has to move from one place to other. Now, what will happen is you will stay in the same Zoom meeting, whatever meeting they will be giving, and the examiner will change and they will come into the meeting. That 5-hour changeover time will be there. Okay. And the few tips what are given, these are taken only from the ESICM website, EDIC only. They have told that come to the point and focus on the question content. Don't go haywire. If you know the question, tell, or just move on, or you will lose your time. Okay. The 1 or 2 times prompt can be given to the candidate. What happens is, if you are not answering, the examiner can prompt you a single time. If you answer wrong also, then also the examiner will prompt you in the way they will not tell the answer, but if you are saying wrong, you can consider that he may say anything more you are thinking, anything else you can think of this question. So that means that you are on the wrong side. You can correct, you have got a chance to correct yourself. This is a hint. And for each question, if it is wrong or you are not able to answer, the examiner has the right, he can give one prompt to the student. Okay. At the end, the candidates cannot go back over any missed question. So once the case is over, he cannot go back to the missed question. This is the CCS, that is the clinical case scenario stations. The next one is the computer-based scenario. In this, there are three main domains. One table is about the imagings, one is about the curves, and the third one about the biochemical scenarios. Each CBS session will last for 12 minutes. Okay, so 12 minutes, but 3 minutes time gap is the changeover. So 15 minutes one. So 15 threes are around 45 minutes. You will complete this CBS. The number of pictures or scenarios expected answer per maybe 8 to 12. In these 12 minutes, you will get around 8 to 12 questions in each one. So approximately 1 minute for a question. Okay, so in case of a ECG or in case images, 1 minute is more than enough. You can just see and you can just tell. But what problem occurs in CBS, most of the students fail, is in the curves where the ECGs are there. And regarding the biochemistry, the questions are so big, just you go on reading the question, the 1 minute is over, and the examiner switch over to the next question. You are unable to even complete the question, rather than, means, no time even to think of the answer. Question only you will not be able to read. Okay. And the last thing is, to pass the EDIC 2, a candidate must pass at least 2 CCS and 2 CBS. CCS, there are total 4 cases, but the 2 short cases, they combine the marks and consider it as one case. So you have to pass one of the 2 long cases and both the 2 short cases, or either way. Out of the 3, 2 you have to pass, and in CBS stations, out of the 3, any 2 you have to pass. Okay, clear regarding the pattern? So in today's class, respiratory, I'll be discussing one respiratory case, that is the CCS, that's a clinical case scenario. In the next class, what I will do is the remaining this case, plus I'll discuss some CBS also in table 𝑬𝑰𝑪. In respiratory, whatever comes, like images can come, the curves can come, biochemistry, few questions. So we'll be discussing it in the next class, what will be happening in the January. Okay. So this is the first vignette which will be given to you. You will get 10 minutes time in the first vignette so that you can read it. During that time, you are eligible. You can take down the notes. You can keep a pen and paper with you. Important highlights which are abnormal in the patient, you can just note it down. Once you note it down, you can expect what questions will be asked to you. So you get mentally prepared what the examiner wants and what questions can come to you, so that they just don't go like a bouncer to you, that suddenly some question is asked. Like the type of case, you can expect the questions and you can just revise it in your mind previously. Okay, anyone from the students want to just read this out?
42 years old female with no comorbidities presented to emergency department with fever, myalgia, malaise, cough, with expectoration and acute onset of breathlessness for 4 days. On examination, she was found to be febrile restless with respiratory rate of 42 per minute, pulse rate 131 per minute, blood pressure 150/80, respiratory rate 35, and oxygen saturation 79% on room air. On systemic examination, crepitation and bronchial breathing sound in right lower zone. Chest diagram showing a non-homogeneous capacities.
Opacities, I think, spelling mistake.
Opacities. In right lower lobe with air bronchogram. No past history of admission to hospital in recent past. Patient is a known case of diabetic and an oral anti-hypoglycemic agent and is well controlled.
Okay.
So from this,
now next, this is the ABG. pH is 7.34, carbon dioxide. Yes, you can read out.
Yes, it's showing respiratory acid. Okay, BCO2 is 48, BO2 is 51. Bicarb 23.9, base X is 2, anion gap 7.6, lactate 1.1. So mild respiratory acidosis only.
Okay, so this is the X-ray. X-ray.
Lower lobar pneumonia, right lower lobar pneumonia.
Okay, so see, what I'm telling you is, in every case, what will be given to you, just one, the clinical findings will be there. Second, the lab findings will be there, and some imaging will be there. So these 3 things will be given in the first vignette, which you will get 10 minutes. You can just analyze. Now, this case, grossly, you're understanding it's a respiratory case, desaturation is there. Then important points, you can note down whatever is there in this. And then you can expect how the questions will come. Okay. Now, the first question in this case is, what are your differential diagnosis in this patient? If anyone wants, they can answer. What DDs you think can occur in this patient with this type of X-ray and this type of presentation?
This is right lower lobar pneumonia with acute respiratory failure type 1.
Yeah, this is right lobar pneumonia. This is the first question. There are differential diagnosis. Any more thing you can cause this?
Differential diagnosis. Pulmonary embolism can be.
Yeah, can be there with this.
Aspiration pneumonia.
Yeah. Aspiration pneumonia. Very good. Right lower zone patch. Always tell a DD as aspiration pneumonia. It can occur. You never know. Anything more?
Pleural effusion, but it doesn't look like.
No, doesn't look much like an pleural effusion. See, one thing I'm going to tell you is, see, in previous EDIC 2 exams, what happened was they had separate pointers. You know what are pointers? Like the answers the examiner have. If they say lower lobe pneumonia, that will be a five pointer for this case. Means that is almost certain this is the diagnosis. And other DDs will have, some will have 3 marks, some will have 2 marks. So if you tell those DDs, you will get marks accordingly. If you tell the 5 pointer, you get 5 marks. If you get 3 pointer, 3 pointer. But this has been abandoned by ESICM because much more variation and criticism was there. So now what is there is, all the DDs what are written in the answer sheet of the examiner, each carries 1 mark. Okay, so even if you are very certain this is lower lobe pneumonia, you have to tell the differential diagnosis, because even if it is a pulmonary embolism is written in his, or rarest of the causes there, that also carries the same mark. Okay, you understood what I'm trying to emphasize? So whatever DDs comes to your mind, you can tell related to this respiratory, because they see there is no negative marking. If even if that is wrong, the examiner will delete it. Okay, that is nothing is there. Whatever right answers you will give, they will tick. The one examiner will be asking, the other examiner will have iPad. The other examiner, he or she has only the work just to tick down what correct answers you are saying. So DDs, many DDs it can be bronchitis, acute exacerbation, COPD, aspiration pneumonia. You told very correctly. Aspiration, then pneumonia is there. Bronchogenic carcinoma at dense opacity in the right lower zone. Maybe it may be a carcinoma and then infection has occurred. Pulmonary embolism. These are the common DDs which are there. Okay.